Welcome. In this session, we'll be discussing about the surgical procedures specifically meant for pediatric glaucoma, goniotomy and trabeculotomy. Goniotomy and trabeculotomy are considered as angle surgeries and are treatment strategies for congenital glaucoma. They improve outflow facility through the physiological path by removing the obstruction at the angle and creating a direct path for drainage of aqueous humor from the anterior chamber to the Schlemm's canal. And this is in contrast to trabeculectomy and glaucoma drainage devices, in which drainage path for aqueous humor is created from the anterior chamber to the subconjunctival space, bypassing the angled structures such as the trabecular meshwork and the Schlemm's canal. Both goniotomy and trabeculotomy require an open angle, and in addition, goniotomy requires adequate visualization of the angle intraoperatively. Angle surgery is usually performed during examination under anesthesia session itself and is performed bilaterally if required. Corneal haze can be cleared with preoperative lowering of intraocular pressure, and in pediatric patients, usually topical carbonic anhydrase inhibitors are employed, but topical beta blockers can also be used with adequate caution. Corneal haze can also be reduced with intraoperative application of glycerin or hypertonic saline on the cornea and by epithelial debridement. Apraclonidine 0.5% can be applied adjacent to the limbus in the quadrant planned to be treated to prevent reflux hyphema, which is very common during angle surgery. Pilocarpine can be used to constrict the pupil to avoid damaging the crystalline lens during angle surgery, but pilocarpine may lead to shallowing of the anterior chamber due to forward shift of the lens iris diaphragm. We start with goniotomy, and goniotomy is an ab interno procedure in the sense that the angle is approached from inside the eye. And as we have discussed, goniotomy is the preferred procedure when intraoperative visualization of the angle is adequate, and this is very important to remember. For goniotomy, surgeon sits opposite to the angle quadrant to be operated on, as shown here in this diagram. The eye is rotated away from the surgeon in the direction of the angle quadrant to be operated on, and fixation locking forceps can be applied on rectus muscles through the conjunctiva to hold the eye in this tilted position. The microscope is tilted towards the surgeon away from the angle quadrant to be operated on, and a direct gonio lens is placed on the eye to visualize the angle. And this direct gonio lens should be small enough to allow entry of goniotomy knife or needle through the limbus. A goniotomy knife or a 25G 1.5-inch needle is introduced into the eye through the limbus diametrically opposite to the angle quadrant to be operated on. And this needle is then passed carefully across the anterior chamber parallel to the iris to the angle quadrant to be operated on. The goniotomy knife or needle is used to incise the anterior trabecular meshwork, and this incision is extended on either side for 2 to 3 clock hours for a total of 4 to 6 clock hours of incision, as shown in this diagram. During the creation of this incision with the needle, the movement of the needle should be smooth without any resistance and should be maintained at the same depth of the trabecular meshwork. The needle is then removed and the anterior chamber reformed. As we have mentioned, a small amount of reflux hyphema may occur following the goniotomy incision, but usually stops after the anterior chamber is reformed. Unlike goniotomy, which is an ab interno procedure, trabeculotomy is an ab externo procedure in the sense that the angle is approached from outside the eye, and trabeculectomy is the preferred procedure for pediatric glaucoma when intraoperative visualization is inadequate because of associated corneal haze. Trabeculotomy is usually planned in the temporal quadrant to spare the superior conjunctiva for future trabeculectomy if it becomes necessary. But when trabeculotomy is combined with trabeculectomy, the procedure is done in the superior quadrant. We'll first discuss the steps with diagrams before we see a surgical video. For trabeculotomy, the eye is positioned as for trabeculectomy, and a limbus-based or fornix-based conjunctival flap is created. As in trabeculectomy, a 3 mm partial thickness scleral flap is raised as shown in this diagram and is extended till the anterior bluish limbal zone is reached. A paracentesis is made to access the anterior chamber as and when required. Then a 2 millimeter long radial incision is gently made at the sclerolimbal junction and is progressively deepened till the Schlemm's canal is reached and identified. And when the Schlemm's canal is incised, there will be leakage of clear fluid or blood which will be detected at this incision. The Schlemm's canal lies immediately anterior to the circumferential fibers of the scleral spur, which lies in the posterior gray zone of the limbus. So the limbal zone underneath the scleral flap will appear to have two zones, an anterior bluish zone and a posterior grayish zone. The Schlemm's canal is located in the anterior bluish zone and the scleral spur is located in the posterior grayish zone. Before the actual trabeculotomy incision, which we will be discussing next, patency of the Schlemm's canal may be confirmed by passing a 6-0 suture into the Schlemm's canal on either side of the incision with minimal resistance. The tip of the 6-0 suture should be blunted with cautery so as to avoid false passage into the suprachoroidal space. For the trabeculotomy incision, a pair of Harm's trabeculotome, a right one and a left one as shown here in this photograph, are used to incise the inner wall of the Schlemm's canal and the trabecular meshwork, with the right Harm's trabeculotome used for the right side of the incision and the left Harm's trabeculotome used for the left side of the incision. Viscoelastic is injected into the anterior chamber to make the eye firm and deepen the anterior chamber to prevent injury of the iris, cornea or the crystalline lens by the trabeculotome. So each Harm's trabeculotome has two arms, and these are called the distal arm or the inner arms, and these are called the proximal or the outer arms. The distal arm of a trabeculotome is introduced into the Schlemm's canal as shown here in this diagram on the respective side of the incision for 2 clock hours circumferentially. The proximal arm of the trabeculotome, which lies external to the eye and is not shown here in this diagram, helps in judging the position and movement of the distal arm which lies inside the Schlemm's canal. The trabeculotome is then rotated inwards as shown here in this diagram till 2/3 of the distal arm of the trabeculotome ruptures through the inner wall of the Schlemm's canal and the trabecular meshwork and enters the anterior chamber. The trabeculotome rotation should be with minimal resistance, parallel and anterior to the iris. This trabeculotome is then removed, and then the other trabeculotome of the pair is similarly introduced and maneuvered in the Schlemm's canal on the other side of the sclerolimbal incision. Some amount of hyphema may occur during this maneuver, which usually spontaneously ceases. The scleral and conjunctival flaps are then closed as in trabeculectomy. Now we have the surgical video of trabeculotomy, and it starts with the superior corneal traction suture. Here a limbus-based conjunctival flap is raised. And a triangular partial thickness scleral flap made. The scleral flap is dissected till the anterior bluish zone of the limbus is visible. Here the radial incision is made and is progressively deepened to expose and incise the Schlemm's canal. Then the distal arm of the left Harm's trabeculotome is introduced into the Schlemm's canal. And rotated inward. following which the distal arm of the right harm's trabeculotome is introduced into the right side inside the Schlemm's canal. And is rotated inward. Here a trabeculectomy is also being done by removing a corneoscleral block of tissue. And a peripheral iridectomy done. The scleral flap is sutured. And the conjunctival flap sutured. There are alternative techniques to standard trabeculotomy. In viscotrabeculotomy, sodium hyaluronate is injected in the Schlemm's canal before passing the trabeculotome, and viscoelastic in the Schlemm's canal is said to prevent collapse of the Schlemm's canal and to hold the incision in the inner margin of the trabecular meshwork apart. In another technique, a 6-0 polypropylene suture with its tip blunted with cautery or an illuminated microcatheter which helps in visualizing the lumen of the Schlemm's canal is introduced into the Schlemm's canal from one side of the sclerolimbal incision and pass 360 degrees around within the Schlemm's canal till it is externalized through the other end of the sclerolimbal incision. The two ends of the suture are then pulled in opposite directions till the suture cuts through the inner margin of the Schlemm's canal and the trabecular meshwork circumferentially and enters the anterior chamber from where it is externalized through the incision. In another alternative procedure called Gonioscopy assisted transluminal trabeculotomy or GAT, two paracenteses are made, one in the temporal quadrant and the other in the supranasal or inferonasal quadrant. Then a goniotomy knife or needle is introduced through the temporal paracentesis and a 1 to 2 mm nasal goniotomy is made. Then a 6-0 suture or an illuminated microcatheter is passed 360 degrees circumferentially within the Schlemm's canal from one end of this goniotomy incision to its other end and externalized through the nasal paracentesis. The two ends of this suture or the microcatheter is then pulled in opposite directions so as to rupture the inner face of the Schlemm's canal and the trabecular meshwork. Like goniotomy, GAT spares conjunctiva for future filtration surgery, but unlike goniotomy, GAT can treat 360 degrees of the angle. Instead of trabeculotomy alone, many prefer to do a combined trabeculotomy and trabeculectomy in the superior quadrant, and the trabeculectomy procedure is done following the trabeculotomy procedure, as we have seen in the surgical video. For the trabeculectomy, a corneoscleral block is removed from the scleral bed underneath the flap. including the region of the sclerolimbal incision which we have discussed with trabeculotomy, and a peripheral iridectomy is also done. Antimetabolites are often used in pediatric glaucomas, but adequate precautions are required, which we have discussed in the session on trabeculectomy. Following angle surgery, an eye patch with an eye shield is recommended. Like any other pediatric eye surgery, an antibiotic and steroid eye drops are prescribed. The child is reviewed every 2 weeks, and the effect of goniotomy is usually apparent within 6 weeks with lowering of intraocular pressure, widening of the angle, with better visualization of the ciliary body band and the scleral spur in the treated angle quadrants. Complications of goniotomy and trabeculotomy procedures include hyphema, which rarely may require drainage, lens and iris damage, and infections. Complications associated with trabeculotomy include Decimet's detachment, iridodylisis, and creation of false passage either into the suprachoroidal space or into the anterior chamber, but not through the trabecular meshwork. We have discussed the difficulties in pediatric glaucoma surgery in the session on pediatric glaucoma, and they include abnormal anatomy of the limbal region in enlarged eyes, small palpebral fissure, thin sclera in pediatric enlarged eyes, need for suture closure of all wounds, which may potentially induce astigmatism and contribute to amblyopia, need and planning in advance for repeat surgery, and poor adherence to post-op instructions by children. Angle surgery may be repeated, particularly if the previous procedure had produced substantial but not adequate lowering of intraocular pressure. Goniotomy can be repeated more than once in untreated angle quadrants, and trabeculotomy can be repeated once if 360 degrees trabeculotomy was not done in the first sitting. As we have discussed in the session on pediatric glaucoma, angle surgery is said to have a favorable prognosis in primary congenital glaucoma, in which it has almost a 90% success rate if the diagnosis is made between 3 months and 1 year of age. Angle surgery is also said to have a favorable prognosis in juvenile open-angle glaucoma, steroid-induced glaucoma, and in uveitic glaucoma eyes in which the inflammation is controlled and the angle is open. Angle surgery is said to have an unfavorable prognosis in primary congenital glaucoma patients diagnosed either before 3 months of age or after 1 year of age, and in secondary pediatric glaucomas such as Sturge-Weber syndrome, neurofibromatosis, Axenfeld-Rieger syndrome, aniridia, aphakia, and Lowes syndrome. But it has been seen that infantile onset glaucoma from these entities do respond to angle surgery, but not as well as primary congenital glaucoma. In a given clinical scenario, both goniotomy and trabeculotomy are equally effective, so failure of one of these procedures precludes reoperation with the other. And many studies have shown that combined trabeculotomy and trabeculectomy has similar efficacy as either goniotomy or trabeculotomy. With both goniotomy and trabeculotomy, IOP lowering efficacy decreases with time, and one study has reported efficacy of as high as 97% at 5 months to as low as 50% at 11 years following surgery, with or without additional anti-glaucoma medications. To recap the salient points, goniotomy and trabeculotomy are angle surgeries indicated in congenital glaucoma. They attempt to improve aqueous outflow through the physiological pathway by draining aqueous humor directly from the anterior chamber to the Schlemm's canal. They are very effective in lowering intraocular pressure in primary congenital glaucoma diagnosed between 3 months and 1 year of age. They are also effective in infantile onset glaucoma in conditions such as Sturge-Weber syndrome, Axenfeld-Rieger syndrome, aniridia, and neurofibromatosis. Both goniotomy and trabeculotomy require an open angle. Goniotomy in addition requires a clear view of the anterior chamber. Goniotomy is an ab interno procedure in which a goniotomy knife or needle is introduced into the anterior chamber through the limbus and is used to incise 4 to 6 clock hours of the trabecular meshwork in the opposite quadrant. Trabeculotomy is an ab externo procedure in which a partial thickness scleral flap is made as in trabeculectomy, following which a radial incision is made in the anterior bluish limbal zone to incise the sclems canal. Then the distal arm of Harm's trabeculotome is introduced into the sclems canal through this incision for 2 clock hours and then rotated centrally to rupture through the inner wall of the sclems canal and the trabecular meshwork and enter the anterior chamber. Variations on trabeculotomy include viscotrabeculotomy, 360 degrees suture trabeculotomy, and gonioscopy assisted transluminal trabeculotomy. Complications of angle surgery include hyphema, iris and lens injury, and infections. Complications of trabeculotomy in addition include Descemet's membrane detachment, iridodialysis, and false passage into the suprachoroidal space. Thank you for listening.